Oh, yeah, fantastic. Thank you very much for the kind introduction. And I'm glad to be here. I'm glad to be back, in fact. I have very hazy memories of being in this ballroom as a medical student just down the road at St. Mary's, but that's some time ago, a different century, in fact. So what I'd like to do now is to perhaps take a side step, or depending how you look at it, perhaps a step forward, and look at integration of digital pathology workflows with a specialty which is, I think, closest to us, which is radiology. So I'll be talking about radiology-pathology integrated diagnostics, or RadPath, and to harness the powers of aligned digital workflows. Now I upset the mechanism.
This work, and then next, press next on I don't know, it's because we have it in. I don't know.
Yep, there we go. These are my disclosures. And I'd like to talk to you a little bit about the background for this desire to link up the two specialties, the possible solutions that we might employ, the requirements for those solutions, and also a view of the future. So when we think about integrated diagnostics, this can in fact be applied to all types of diseases, although most work has been performed in oncology. And this involves the extraction of curated quantitative data in multiple domains. So that may be pathology, that may be radiology, that could be microbiology, clinical chemistry, whatever you fancy. And then display the data abstractions in user-friendly dashboards. I think that's important for us as users. And potentially also use computational multimodal data analysis to suggest a diagnosis or provide prognosis and prediction, which informs the patient's treatment and potentially further diagnostic tests. And we could then use this incorporated data to actually feed back into our registries and also link that to outcome of these patients, potentially closing the loop and improving outcomes for patients, and potentially also develop new biomarkers. So the benefits of integrated diagnostics in combining radiology and pathology are manifold. I think the first one that comes to mind is quality control. So if we look at a certain specimen from two angles, and in essence, we look at the same thing with different modalities, as you know, we can check each other's diagnosis. And that's particularly important for the radiologist, because as pathologists, we always have the last word, of course. But this is something that has been proven to be quite beneficial. So then we can try to standardize our reports and integrate them for the clinician, if that's what they'd like, potentially also leading to better and more efficient tumor board presentation, improve clinical efficiency when it comes to ordering additional tests, and develop, as I mentioned before, registries and accrue data for research and improvement of accuracy in both disciplines, but also provide data for research and innovation. And ultimately, of course, this is all to improve patient care. So if you think about it very simply, aligning workflows, that can be aligning physical workflows, such as same-day scheduling of interventional radiology tissue biopsies, and paired with our assessment of these tissues, as happens, of course, for instance, in breast cancer care, potentially even do rapid same-day genotyping. So this is very much about the workflow alignment. And this has been found actually also to lead to a significant decrease in the time to treatment in some studies. And this could potentially also ease the administrative burden for providers and payers. So what about that RadPath workflow alignment then? So seemingly we're dealing with two completely different systems, but if you actually hold those two workflows against each other, there are more similarities than you might imagine. So the first four of these are disparate, I think. So you have the imaging request, of course, and diagnostic request by the physicians, but then there's planning, the examination by the radiologists, and reception and registration of the material on our side. They provide patient instructions. We do grossing according to protocols and frozen sections potentially. They do protocoling on their equipment. We do tissue processing, cutting and staining. But when it comes down to it, eventually we examine these images and we provide a report and discuss these at multidisciplinary meetings. So just to give you an example from my personal hobby, so thoracic pathology. So this is a chest CT, as you can see, and you might have spotted the abnormality, just to provide a little bit of a hint there. So there's quite an indistinct ground glass nodule in the right lung. So this was the first wedge that we got from this tumor. This is the histology, nothing much to be seen there, so just normal lung. Second wedge was done by the surgeon, again sent for frozen section, still no tumor. And then there was an additional wedge excision. We, by that stage, of course, looked at the imaging, because we have the imaging available also in the cut-up room. This was the wedge, and then if you cut it up, there seems to be something that would align with what was seen in the CT scan. And actually, by doing that, just during the cut-up, I think this helps us a lot in determining whether the representative section was taken out from that lung. And then if we zoom in, this is in fact an adenocarcinoma, and that perfectly aligns with the CT scan. So why is this important? For lung, for instance, it's important because it determines your classification, it determines your grading, your staging, and therefore also the treatment. So here on the right-hand side, you see the radiology image at the top aligned with what we see in pathology, and that to some extent, of course, is congruent, but sometimes there are also differences. And I think we need to really have both modalities there to actually come to the correct staging, because we don't always know in pathology that we've sampled in the right plane, for instance. And we can also tell something about the margins if we combine the two modalities. And what's particularly important is whether we've been representative. And that has been shown in this case. So in cut-up, you can combine the histology or the frozen section with your radiology images. For instance, also, if you're cutting up a breast lump, looking at the microcalcifications. And we were particularly interested in this analysis in biopsies. So this is something that has already been recognized for a while. So this is a paper from some 13 years ago, suggesting that for this type of concordance workflow, you should, in the end, actually come together as a pathologist and radiologist and discuss difficult cases to see what your integrated diagnosis would be, which you then, of course, feed back to the clinician. So we started a concordance workflow project. We had 100 consecutive patients with a histological biopsy diagnosis of lung abnormalities obtained by CT-guided needle biopsies in our hospital. All of the images and diagnostic reports were available. All the scans and histology scans were available, and they were fed into a standalone system on a computer and actually in the IDS-7 system provided by Sectra. And this allowed then side-by-side display and accessibility of images of radiology and histology, as well as our reports, so the classification and the registration by us, so by me as a pathologist and also by the radiologist, when it comes to the estimate of the malignancy or potentially benign nature of these lesions. And then we came to this concordance map, as it were, where if I reported something as uncertain benign and the radiologist called it benign or the other way around, we were in essence concordant. If both were uncertain, that's not great, but then we're still concordant. And the same also applies to malignant, uncertain malignant. Everything else would be discordant. And we had 3 reconciliation rounds. So we independently classify them according to this schematic. And then an automatic comparison was done by the software. In the second round, these discordant cases were discussed again. The radiologist reclassified their diagnosis in some cases, and then again, automatic comparison was done. And then eventually in a third round, because apparently we hadn't come to reconciliation, we discussed these discordant cases to see what the differences were in opinion. And this is what the flowchart looked like. So we start off with 100 patients. Already in the first step, we saw that 11 of these were non-representative when it came to the histology. And then we're left with 21 discordant cases in the first round. So that's actually quite a lot. It's almost a quarter of these patients. Then we had the first round of reconciliation, and then a few of these were reclassified as malignant. Some were reclassified as benign. We were left with 7 discordant cases, and in the third joint evaluation, these were still remaining. And this is what the discordance was derived from. So in radiology, it was an uncertain diagnosis in 3 of the cases. They were shown by pathology to be malignant. I think this is not a true discordance, probably, but perhaps just a limitation of the radiological technique. But then there were some interesting cases which were classified as malignant by radiology and benign by us. And sarcoid, well, that's something that you can resolve at an MDT. Or the most worrying case perhaps was at the, which you can see on a number 7, defined by us as benign and by radiology as malignant. And this later on was proven to be a disseminated lung carcinoma. So this is the sort of case that you would like to pick up because apparently there was an unrecognized lack of representativeness in this biopsy. So there are some difficulties of introducing this into your practice. The most important bottleneck that we identified in several of these studies that we've done is to link the diagnostic procedure on the radiology side and the pathology side. Often they have a diagnostic CT scan and then a biopsy CT scan. So which one do you take? There are often multiple examinations. There's a right versus left, for instance. So somebody needs to decide which examinations need to be linked. And so far, we haven't found a way of doing this in an automated fashion. So I think sometimes the radiologists and pathologists still need to resort to looking at the timelines. For many of the cases, this will be automated. How do you assign medical legal responsibilities if you compile an integrated report? So is that 50-50? Does it depend on the examination of the radiologist or the pathologist and what was actually seen in the scan, or is the eventual report the one that decides the liability? The precise role in the diagnostic process hasn't been clarified for us yet. So does it run in the background without the clinician knowing it, or is it linked to the MDT, for instance? It is potentially time consuming, so it adds to our workload. And therefore, we need automated pre-selection of indications, potentially. And this is an important one. Is this going to be accepted by clinicians? So do they want these integrated reports? Some of our clinicians have said to me, well, I know damn well how to integrate these different domains. So why would you like to do that for us? And when it comes to the requirements for this RadPath workflow, you need administrative alignment of the subspecialties. You need to streamline your tests and your procedures as much as you can. And that is an interdisciplinary design process. So it really involves both sides, of course, with making interdependency charts, workflow diagrams, and team alignment meetings. You need to collaborate and negotiate with your funders, and that may not, of course, be available in all institutions. And you need to have a culture of collaboration and trust and sharing. So as we're both looking at the same sort of structures from different angles, we are perhaps encroaching on each other's field of expertise. And finally, I think if we're going to introduce this, of course, we need education on both sides to deal with these sort of workflows. Then there are considerations also for your IT architecture, and you need to think about the level of which you do your integration. So this is a very simplified schematic. What we've decided to do at Erasmus is to create a vendor-neutral archive, so all images from the radiology packs and the pathology packs then go into a single archive. This has its challenges, I can tell you, but I think this is a way of actually being able to link the data, and they're also available to both specialties. In practice, of course, it's much more difficult, and I won't go into this chart, but when it comes to IT infrastructure, of course, that's sometimes something that can slow us down. And then talking about the level of integration, so this could be at the level of the workflow, as we've just discussed. We can do that at the viewer level, or we can potentially do that by data integration. This could be AI aided. So the workflow integration can be at the level of the diagnostic question. I think we should ideally have the same question on both sides. At the level of order management, so in our institution, this has been harmonized, and that also includes an efficient order process. Ordering the relevant tests from different specialties, perhaps not between radiology and pathology, but it may be important if you think about other specialties, not to double up tests that are not potentially useful. Then providing the integrated report and then sending that through to the hospital management system or information system. And lastly, how to integrate this at multidisciplinary meetings. So we've done that for various different types of workflows. So this is one of the simpler ones where we're describing that project that I talked about earlier. We have the radiologist who compiles a report, and the pathologist, of course, in second instance, after the biopsy is done, that goes back to the radiologist and so on, and then you have your reconciliation workflow. But this very quickly becomes quite complicated. So this is the viewer that we used. You will see a cursor going somewhere. Yeah, so there's the pathology and the radiology GUI. So you have your dashboard there, sitting one on top of the other. At the bottom, there's the relevant thumbnails from the various investigations. So in the previous one, you saw the CT scans. Now this is the pathology scans, and on the right-hand side, you can actually look into the details of the pathology report. So the radiologist can read up on this, and then if they want to, they can have a look at the slides. Not sure that always helps, but I think that is at least a capability that can be there, and the other way around as well, of course. And then eventually you compile your report and you classify accordingly, and potentially also resolve one of the discordances. So what about data integration by AI then? So we've heard about the large language models, so they can serve as tools to summarize and extract structured and actionable information from our reports, and actually also convert that perhaps to synoptic reporting. And they can be used on the images themselves, of course, these models, to segment tumors and extract features automatically, and then use that for classification. And eventually, I think that's the most interesting part, you can actually fuse the data. And this is a nice schematic where you can see that in a sort of high-level overview, where you have the different domains on the left-hand side. So there's image data from radiology and pathology, of course, but also potentially from clinical camera images, and there's lab test results and clinical data. That can all be fed into a multimodal learning model, which can then produce a diagnosis or prognosis for the patient. So far, so good. I think that's the aim. But then you need to decide, are you going to fuse the data at the feature level? So you're going to look at the images themselves, or are you potentially going to fuse at the decision level when we've compiled our report? So, and both are potentially possible. And then when you're designing these models, it also depends on which fusion model you want to use. So to the AI specialists in the room, these will be familiar. So you can go from an operation-based fusion to a dension-based, etc., all the way to a graph-based fusion where you look at interconnectivity. And these can then be combined in an early phase where you just feed the images to a single system fusion model, or you can actually analyze them separately by AI and then use the output to come up with a prediction or prognosis, or you can use them sort of more intermediate system where you lie between these two extremes. And again, here it depends on which neural network you use or other type of model, what you want to achieve. So it depends on whether you want to have that sort of biological explainability or robustness in assessing the images. So I think there are some choices to be made when it comes to the eventual use of the data also in your clinic. And there are some examples out there that this could actually be beneficial. So this is from my own specialty, from lung, where radiomic and pathomic model was trained, and then a RadPath model in the end was developed. And you can see that here on the right-hand side has a better predictive capability when it comes to survival, but also potentially determining the best course of action. So actually signaling those patients which would have a poor survival, a poor outcome after surgery, for instance. So you can ask very specific questions if you train it in that way. And then you can have the images fed back to you. So there's an element of explainability here, where both the radiology images and the pathology images can be in a GradCam approach, can tell you, where the model is focusing to determine whether you're either a low risk or a high risk patient, as we know that from other studies, of course. Prostate, very similar thing, has been done there. In essence, having a radiomic and a pathomic model, and then at the end having a more of a statistics-based fusion to create what they call the raptomics classifier. Again, the RadPath model outperformed both the radiomic and the pathomic model with a very remarkable hazard ratio of around 11. So I think there is real benefit in potentially introducing this into clinical practice. And here they also have a sort of feedback loop showing us the areas that the models have been focusing on. And you can add in other data. So in addition, of course, to the radiology and the histology, you might add in your genomic data. And that's been done in this study. On the right-hand side, you see the models with the highest AUC are the ones that combine all of the data for outcome in lung cancer. So to summarize, routine radiology pathology integration, as I've described, can be important for adequate classification and staging of tumors in the field of oncology, to assess representativeness and thereby also increase quality. It can offer, I think, improved efficiency if you use it in the right way. Reduce medical errors, I think that's important, and also produce integrated reports. But I think we are now looking towards using AI to actually provide that data integration for us and fuse the data. And a bit like the previous speaker has mentioned, I think we need vision and subsequent actions to enable implementation. And I think that goes for all aspects of AI. We've tried to do that by hiring a talented postdoc who's shared 50-50 by the radiology and pathology department, trying to align us and actually come up with an integrated diagnostics model. He's funded by AI Ned, and that's Martijn Starmans. And perhaps we can even look at taking a step further. So there are now some departments, mainly in the US, where pathology and radiology share perhaps, if not the same monitors, at least the same department. Perhaps we need to think about having a combined curriculum because we do look at the same structures with these different modalities, and actually also mix in a little bit of AI while you're at it, and then come to a common certification for these radiopathologists or pathoradiologists, whatever you want to call them. And that leads me to just acknowledge the contributions of our radiologists, Arlette Odink and Jan-Jaap Visser and Sectra, all the people from Sectra helping us with this project.